In this module, we will discuss most disorders that mostly affect children and adolescents. We will focus on intellectual development disorders, autism, ADHD, opposition defiant, Tourette, conduct, intermittent explosive, separation anxiety, and other childhood disorders. We will review the predisposing factors and therapeutic approaches. Some symptoms of childhood disorders first become evident during infancy, childhood, or even in later adolescence. Behavioral responses are individual and idiosyncratic. They are, indeed, human responses. Guidelines for making a determination if a behavior constitutes emotional problems should consider the appropriateness of the behavior regarding age and cultural norms, and whether the behavior interferes with adaptive functioning. It is not easy to diagnose some childhood disorders, such as depression and anxiety. Some of these symptoms may mimic behavioral problems in children. Our focus will be on the nursing process to identify the underlying factors, such as trauma, anxiety, neurodevelopmental disorders that may lead conduct disorder, oppositional defiant disorder, and disruptive disorders, among others. Please note that intellectual disability, once called mental retardation, is a disorder with onset during the developmental period that includes both intellectual and adaptive functioning deficits in conceptual, social, and practical domains. The incidence rate in the general population is about 1%, and onset occurs during the developmental period. Intellectual development disorder affects children's ability for self-care, noticeable deficits in reasoning and learning, decision-making, and abstract thinking. The level of deficits or severity range from mild, moderate, severe, or profound. Such a severity is based on adaptive functioning within the three domains. Most children receive help from individualized education programs, also known as IEPs, and are put in self-contained classrooms. The category of autism spectrum disorders, ASDs, encompassed a broad spectrum of diagnoses that included autistic disorder, Rette's disorder. Rett causes a progressive loss of motor skills and language. Asperger syndrome, a neurodevelopmental condition characterized by significant difficulties in social interaction and nonverbal communication, along with restricted and repetitive patterns of behavior and interests. The syndrome is no longer recognized as a diagnosis in itself, having been merged with other conditions into autism spectrum disorder, ASD. ASD is a lifelong developmental disability, which is adapted to each individual by clinical specifiers, for example, level of severity, verbal abilities, personal functioning. ASD includes a wide range of symptoms and levels of severity that impact thinking, feeling, communication, and social relationships. Behavior is often limited and repetitive, but each child is likely to have a unique pattern of behavior and level of severity from low to high functioning. The Centers for Disease Control and Prevention Autism estimates that 1 in 59 children in the United States are identified with ASD. The disorder occurs about 4 times more often in boys than in girls. Almost one-half, 44%, of individuals with ASD have an average or above average IQ. However, most children with autism have limited ability to communicate and interact with others. About 15% of ASD cases are related to a known genetic mutation. In most cases, its expression is related to multiple genes. There are also prenatal and perinatal influences, such as advanced parentage, fetal exposure to valproate, gestational diabetes, and gestational bleeding. Some individuals who meet criteria for ASD may be highly functional and highly intelligent in spite of communication impairments and repetitive or restrictive behaviors. Symptoms in ASD include impairment in social interaction. Children with ASD have difficulty forming interpersonal relationships with others. They show little interest in people and often do not respond to others' attempts at interaction. Impairment in communication and imaginative activity. Both verbal and nonverbal skills are affected. In more severe levels of ASD, language may be totally absent, restricted activities and interests. Even minor changes in the environment are often met with resistance or sometimes with agitated irritability. Attachment to, or extreme fascination with, objects that move or spin is common. Stereotyped body movements, hand clapping, rocking, whole body swaying, and verbalizations, repetition of word phrases, are typical. Clients with ASD have several physiological and physical difficulties. They include sensory integration dysfunction, feeding and digestive disorders, and sleep disorders. Some of them may be allergic to different items or even have seizures. The outcome criteria include short and long-term goals. Timelines are individually determined. Goals for treatment of a child with ASD should focus on preventing self-harm, helping the client initiate social interaction, establishing a means of communicating needs, and helping the client to develop ego identity. Interventions should include working with the child on a one-on-one basis, giving positive reinforcement, and assisting the child in recognizing separateness. Pharmacological interventions are directed toward relief of targeted irritability symptoms such as aggression, hyperactivity, self-harm, impulsivity, and temper tantrums. There are no medications that treat the core symptoms of ASD. The U.S. Food and Drug Administration, FDA, has approved 2 medications for the treatment of irritability associated with ASD, risperidone, Risperdal, in children and adolescents 5 to 16 years, and aripiprazole, specifically Abilify, in children and adolescents 6 to 17 years. Other antipsychotics, such as olanzapine and quetiapine, are used to target behaviors, such as aggression. These children with ADHD are highly distractible and unable to contain stimuli. Motor activity is excessive, and movements are random and impulsive. The onset of the disorder is difficult to diagnose in children younger than age 4 years, because their characteristic behavior is much more variable than that of older children. Frequently, the disorder is not recognized until the child enters school. It is estimated that in 50 to 70% of the cases, ADHD persists into young adulthood and beyond, and unlike other psychiatric disorders that are typically episodic, the adult with ADHD has symptoms that are chronic and unrelenting. Symptoms of hyperactivity include fidgeting, excessive talking, unable to sit still, inattention, and distractibility. Clients with ADHD have a hard time focusing on assigned tasks. Most clients diagnosed with ADHD present with impulsiveness. They lack reflection in their decisions as they do not consider their consequences. They are high-risk takers and engage in self-harm activities or behavioral urges due to impulsivity. Pharmacological intervention, particularly CNS stimulants, are considered the first line of treatment for ADHD. The mechanism of action is unclear, but because these drugs are believed to elevate dopamine and norepinephrine levels, it has been hypothesized that their effectiveness is in response to neurotransmitter dysregulation. They have generally mild side effects, but are contraindicated in anyone with cardiac problems or risks for cardiac problems. There is an increased risk for new-onset psychosis with amphetamine stimulants, which release about 4 times as much dopamine as methylphenidate. A recent study using trigeminal nerve stimulation in clients with ADHD proven potential benefits for improving attention and decreasing both hyperactivity and impulsivity. Some common side effects of CNS stimulants include decrease in rate of growth and development and insomnia. Some children end up stunting, not growing at the expected rate of growth. Other concerning side effects include decreased appetite and weight loss. It is exclusively recommended not to use caffeine while taking CNS stimulants. They should never be discontinued abruptly. Also, due to insomnia, give the last dose of the day at least by 4 p.m. Avoid any medications that may contain caffeine, such as Excedrin or decongestants. Non-stimulant medications used to treat ADHD include atomoxetine, bupropion, and guanfacine. Such medications may cause appetite and growth suppression, however, such side effects are minimal compared to CNS stimulants. They can be administered either before or after meals. It is highly advisable to monitor the risks of suicidal ideation in clients taking CNS and non-CNS ADHD medications. Tourette's disorder, a neurological disorder with sudden unwanted and uncontrolled rapid and repeated movements or vocal sounds called tics. It is characterized by the presence of multiple motor tics and one or more vocal tics, which may appear simultaneously or at different periods during the illness. This may cause distress or interfere with social, occupational, or other important areas of functioning. The age at onset of Tourette's disorder can be as early as 2 years, but the disorder occurs most commonly during childhood, around age 6 to 7. Prevalence of the disorder is estimated between 3 to 8 per 1,000 in school-aged children. The lifetime prevalence is estimated to be about 1%. The motor tics of Tourette's disorder may involve the head, torso, and upper and lower limbs. Initial symptoms may begin with a single motor tic, most commonly eye blinking, or with multiple symptoms. Initially, tics tend to occur in the face and neck and progress downward to the torso and lower limbs over time. Simple motor tics include movements, such as eye blinking, neck jerking, shoulder shrugging, and facial grimacing. The more complex motor tics include squatting, hopping, skipping, tapping, and retracing steps. Vocal tics include various words or sounds such as squeaks, grunts, barks, sniffs, snorts, coughs and, in rare instances, a complex vocal tic involving the uttering of obscenities. Vocal tics may include repeating certain words or phrases out of context, repeating one's own sounds or words, palilalia, repeating what others say, echolalia. The movements and vocalizations are experienced as compulsive and irresistible, but they can be suppressed for varying lengths of time. Many report a buildup of tension as they attempt to suppress tics to the point where they feel the tic must be expressed against their will. Tics are often worse during periods of excitement and better during periods of calm. 86% of children with Tourette's disorder have at least one mental health, behavioral, or developmental condition. Systematic review of current evidence supports the efficacy of antipsychotic agents, both typical and atypical agents, and the use of alpha-2 adrenergic agonist agents, such as clonidine, in treating tics. Pharmacotherapy is most effective when combined with psychosocial therapy, i.e. behavioral therapy, individual counseling, or psychotherapy, or family therapy. Medications that are used in treating Tourette's disorder include antipsychotics and alpha agonists. The conventional antipsychotics, haloperidol, Haldol, Pimozide, Orap, and aripiprazole, Abilify, have been approved by the FDA for control of tics. Non-pharmacological treatments for Tourette's disorder include comprehensive behavioral intervention. CBIT reduces the severity of tics by teaching how to recognize and manage environmental triggers. Speech therapies are helpful when co-occurring conditions such as social language impairments, learning disabilities, or other communication disorders. Deep brain stimulation, experimental and involves surgical implantation of electrodes to stimulate communication areas of the brain. Deep brain stimulation is an option when all other treatments have been tried and found ineffective. Oppositional defiant disorder is characterized by a persistent pattern of angry mood and defiant behavior that occurs more frequently than is usually observed in individuals of comparable age and developmental level, and interferes with social, educational, occupational, or other important areas of functioning. The disorder typically begins by age 8 and usually no later than early adolescence. Prevalence estimates range from 2 to 16%, and common comorbid disorders include ADHD, anxiety, major depressive disorder, conduct disorder, and substance use disorders. Initially, the oppositional attitude is directed toward the parents, but in time, relationships with peers and teachers become affected. These impairments in social interaction often lead to depression, anxiety, and additional problematic behavior. Usually, these children do not see themselves as being oppositional to the problem as arising from others whom they believe are making unreasonable demands on them. These children are often friendless, perceiving human relationships as negative and unsatisfactory. School performance is usually poor because of refusal to participate and resistance to external demands. With conduct disorder, there is a repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate societal norms or rules are violated. Physical aggression is common, and peer relationships are disturbed. This is one of the most frequent reasons that children and adolescents are referred for psychiatric intervention. Prevalence estimates range from 2% to more than 10%. The prevalence rises from childhood to adolescence, and it is more common in males than in females. There is a higher male predominance among those with the child-onset subtype. Several comorbidities are common with conduct disorder, including ADHD, mood disorders, learning disorders, and substance use disorders. Potential predisposing factors to conduct disorders include genetics, Family, twin, and adoptive studies have revealed a significantly higher number of individuals with conduct disorder among those who have family members with the disorder. As early as age 2, children who show signs of an irritable temperament, poor compliance, attentiveness, and impulsivity can begin to show signs of conduct disorder at later ages. Neurobiological factors. Neuroimaging studies identify decreased gray matter in limbic structures, bilateral insula, and the left amygdala, a high plasma concentration of serotonin and low levels in cerebrospinal fluid, both of which are correlated with aggression and violence. Also, aggressive children had significantly greater relative right frontal brain activity at rest than healthy controls. Poor academic performance and social maladaptation often lead to affiliations with a deviant peer group. The classic characteristic of conduct disorder is the use of physical aggression in the violation of the rights of others. The behavior pattern manifests itself in virtually all areas of the child's life: home, school, with peers, and in the community. Stealing, lying, and truancy are common problems. The child lacks feelings of guilt or remorse. The use of tobacco, liquor, or non-prescribed drugs, as well as the participation in sexual activities, occurs earlier than the expected age for the peer group. Projection is a common defense mechanism. Low self-esteem is manifested by a tough guy image. Characteristics include poor frustration tolerance, irritability, and frequent temper outbursts. Symptoms of anxiety and depression are not uncommon. Level of academic achievement may be low in relation to age and IQ. The most important information to remember about a disruptive mood dysregulation disorder is its characteristics, such as recurrent temper outbursts that are severe and do not correlate with a situation. Temper outbursts are present 3 or more times weekly, observable by others, guardians, peers, teachers, in at least 2 settings: home, school, clinic, etc., and they are not caused by another mental health disorder. Children with intermittent explosive disorder have recurrent episodic violent and aggressive behaviors which possibly hurt someone, property, or animals. They may present with aggressive overreaction on a simple argument. It can result in physical assault on other people. Soon after, these children or adolescents feel remorseful or shameful of their actions. Such a behavior interferes with their jobs and maintaining good relationships. Separation anxiety disorder is characterized by excessive fear or anxiety concerning separation from those to whom the individual is attached. The anxiety is beyond that which would be expected for the individual's developmental level, typically before 3 years old, and interferes with social, academic, occupational, or other areas of functioning. Onset may occur at any time before age 18 but is most commonly diagnosed around age 5 or 6, when the child goes to school. Over 50% experience remission of symptoms within 10 years of onset, but there are several common comorbidities, including panic disorder, social anxiety disorders, sick phobias, depression, and bipolar disorders. Up to 80% of children with school refusal meet criteria for separation anxiety disorder. Interpersonal peer relationships are usually not a problem with these children. They are generally well liked by peers and are reasonably socially skilled. Younger children may follow the person they are afraid to be separated from. The guardians of these younger children may also have a history of anxiety disorders. Worrying relates to the possibility of harm to self or to the attachment figure. The symptoms and assessment of separation anxiety disorder include crying or screaming, throwing tantrums, clinging behaviors to the person they do not want to separate from. This person is usually the mother. Children may even complain of physical problems, such as headaches. If not resolved, it can lead to phobias or even panic disorders. General therapeutic approaches to treatment for disorders that commonly affect children and adolescents consist of behavior therapy, which is a common and effective treatment with disruptive behavior disorders, such as ADHD, ODD, and conduct disorder. With this approach, rewards are given for appropriate behaviors. Family therapy for children and adolescents must involve the entire family if treatment is to be successful. Group therapy provides children and adolescents with the opportunity to interact with their peers. Cognitive behavior therapy, CBT, has demonstrated benefit for tic disorders, separation anxiety disorder, ADHD, ODD. Psychopharmacology, medication should not be the sole method of treatment, but can help improve quality of life for families of children and adolescents with these disorders when combined with psychosocial therapy. As usual, thank you for reviewing this module till the end. You are all done and enjoy the rest of the day.